Hello, my name is Lindsay. I'm going to be talking today about a case study at my field placement. So let me just get that pulled up here. I'm going to just go ahead and share my screen. Okay, so let's see here. Okay, so as far as my field placement, I am at the Adult Partial Hospitalization Program. So patients are referred to us with acute mental health needs. Referrals can come from anywhere ranging from the emergency department, the Comprehensive Psychiatric Emergency Program, or CPEP, the mobile crisis team, and outpatient providers. So all of these different parts of the system work together. So the emergency department could be somewhere that people can go if they have an acute mental health crisis. Sometimes people will go for heart palpitations or chest tightness, which can be then sometimes diagnosed as anxiety. Typically, in that situation, they would be referred to an outpatient provider. Within our system, there are outpatient providers, but people can also go to the emergency department for psychiatric emergencies. So thoughts of harming themselves, thoughts of harming others. And then they would be evaluated to be brought to CPEP, the Psychiatric Emergency Program. When patients come to us, it's typically after they've been hospitalized or if they are working with an outpatient provider and the provider feels that they're not really able to meet them where they're at this time and that they need a higher level of care than your regular weekly or biweekly or even monthly therapy. We see people that have an acute presentation of depression symptoms, anxiety, post-traumatic stress, suicidal ideation, and recent attempts as far as suicide. Our targets for the program are for acute crisis stabilization. So we're focused on safety. We're focused on helping people get back to their baseline and helping people connect to resources. So a lot of people do come from the CPEP, the Comprehensive Emergency Program, or they come from the emergency department and they don't have a therapist, they don't have a psychiatrist. A lot of patients also have severe and persistent mental illness where they will need medication providers going forward. So that's really important for us to help people get connected in the community to those kind of providers. We also help connect with different resources such as family planning services, housing services, helping people connect with food, clothing, and other essentials. So the patient that I want to talk to you all about today is named Charlie. So Charlie is 27 years old. They're non-binary. They use they and them pronouns. Charlie was referred by CPEP to our program. They moved here from California, so they moved across basically the entire United States. When they came to us, they were presenting with suicidal ideation, non-suicidal self-injury in the form of cutting, dissociation that was causing gaps in their memory day to day, a history of childhood trauma, and some extensive depressive symptoms. So just to kind of go over, the present illness, some of the history. So Charlie has a history of severe recurrent depression without psychotic features, suicidal ideation, and substance use. So we know this from the patient's report, as well as some collateral that was done while they were in CPEP. They talked to Charlie's parents, well, Charlie's father, in regards to, family history of psychiatric conditions, as well as, Charlie's own history. Charlie reports being inpatient and psychiatric hospitalization at age 14, twice again in 2019, once in 2020, and one time in 2022. Upon evaluation, Charlie endorsed a lot of different depressive symptoms, including fatigue, reduced appetite, an increase in overall depression and anxiety, significant unintentional weight loss over the past couple of months of 20 pounds, randomly crying more often, and really poor application of activities of daily living. So Charlie was noticing that they were calling out of work more often, that they weren't really reaching out to friends and family. They were having difficulty, showering, taking more time in between when they would normally be taking care of themselves. And for Charlie, this is like a real indicator, like, okay, it's getting worse again. It's time to get some help. So when Charlie was in for interview, this was one of the first times that I had shadowed at the program. So it was a really interesting presentation for me. So Charlie presents as tangential, kind of circumstantial as well. They made minimal, if any, eye contact. Very, I would say, very cooperative, calm. A little bit reactive was what the interviewer had told me as part of his assessment of Charlie. Now with my experience as doing some of the individual intakes, I do see Charlie as someone that, luckily, just like they told us, suffered a lot of trauma and is really doing their best to be cooperative and really doing their best to, stay on task. Charlie did have a craft with them when we did the intake, so they were going to focus on that craft. But, something that we encourage at the program is that people do have things that keep their hands busy. So we have like these little baskets and all the group rooms of different, toys and stuff that people can use because it can be really difficult. And I think that intake can be difficult for a lot of patients. You're coming in, you're talking about really difficult things with a complete stranger to see if they're going to let you in the program. For a lot of people, they don't start with the partial program. If they don't feel that they're able to maintain that safety, they may be going back to the hospital, or they may be starting over completely with a therapist that they're only going to see every couple of weeks. So it can be really difficult, I think, for a lot of people. Charlie's symptoms are making it worse, and more difficult for them to care for themselves, and it's affecting their work. Like I said before, not showering as often, which is something that Charlie really identified as, concern. They said that they're probably showering once every 3 weeks. So as far as medical history, Charlie doesn't report any concerns for medical conditions and was medically evaluated by the emergency department. So Charlie had first gone into the emergency department for psychiatric evaluation, but what they do first is they make sure, nothing pressing as far as that. Charlie's also connected to some providers in the community. So they're receiving Suboxone treatment at outpatient mental health. They have an outpatient mental health therapist. I don't believe they have had a psychiatrist at this point, but they also had a primary care doctor at one of the big community clinics in the Rochester area, which is great as well. So no medical concerns at this time. There was a history that was pretty extensive as far as substance use. So a couple of the things were like, LSD, mushrooms, cocaine, heroin, different things, but nothing currently other than cannabis. So Charlie does use cannabis every day at the point of intake. We would ask Charlie to not use before coming to program and to try their best to try to get use down if possible, maybe working towards not having as much of a dependency on it. When it came to the purposes of the intake, we did diagnose Charlie with a severe cannabis use disorder. There is no other opiate use or other substances since January of last year that Charlie reports. So some of the strengths for Charlie. So Charlie has very good insight. Charlie has a lot of experience in the mental health field. They know the signs, they know the symptoms, they know when they're not getting better, and they know when to ask for help. I think that's really commendable. I think that's something that is really, strengthens them as an individual. They also have good connection to medical and mental health providers. They're taking care of themselves in that way. And I think that that's something that we can just continue to celebrate and, foster in a lot of patients. Keeping them connected, making sure that they're taking care of themselves, even in those smaller ways of, okay, I'm going to go to a primary care doctor once a year. Charlie has a willingness to engage in care. Charlie is the one that came to the hospital in the first place. Charlie came to their intake appointment very early. Charlie was ready to start, ready to go, ready to get help, and was like that the entire time that they were in program. Charlie was very cooperative in the interview when I was there. Like I said before, with the insight I have from doing some of the intakes on my own and understanding that every intake interviewer and evaluator has different experiences and different kind of ways about doing things, that my interpretation was that Charlie was cooperative and does have really good insight into what they're experiencing. Charlie has a small but very strong support system. Charlie's best friends are their roommates. Charlie still talks to their father who lives back in California. but I definitely think that that's a strength. That kind of plays into the protective factors for Charlie for suicide. So they're friends, they really care about their work. And the last but not least, creativity. Charlie is an artist. Charlie makes a bunch of, artistic things. They express themselves very artistically. And I think that's a really beautiful strength for them to have, especially in their care in a group setting. There's a lot of opportunities to do creative wellness kind of things. There's a lot of opportunity, I think, and we'll talk about this a little bit more later as far as the behavioral activation for Charlie. So I definitely feel that that was another strength. Okay. As far as treatment planning, the program itself, so the partial program provides evidence-based care for depression symptoms. So we offer supportive therapy, group therapy with elements of psychoeducation, cognitive behavioral and dialectical behavioral approaches, and we also offer medication management. So Charlie's responsibility as a patient would be to practice skills and challenge cognitive distortions to find success in the program. So we'd be asking Charlie, every day after, coming in the morning, like, tell us about your day. After a program, what did you do? What skills did you use? What have you been doing? What have you been getting out of the program? Every time that Charlie would meet with their individual therapist, which is about 3 times throughout the whole program, or meeting with a nurse or a nurse practitioner, they would be asked, what skills have you used? What have you learned? What's been helpful? Do you have questions? So they would have that responsibility of practicing those skills, and one of those being the cognitive distortions. Now, for patients with suicidal ideations, cognitive behavioral and dialectical behavioral therapies are desired interventions to reduce the risk. So when Charlie came to us, they were at a elevated risk for suicide. We used the Columbia as far as assessing suicide, as well as some very direct questions. So one of the things is that we were focusing on, taking suicide off the table, helping to lessen and decrease those suicidal thoughts, and to help give Charlie the tools. So if they felt they were at risk, if they were having those thoughts come up again, what can they do in the future to decrease those? What can they do in the future to keep themselves safe? So some things just to consider as far as like cultural considerations for Charlie. So it was really important for me, looking at it in this perspective of like staff and patients in the program need to be inclusive of Charlie and our gender identity. One of the things that we do ask of patients is, of course, respecting each other boundaries, being just generally respectful of one another. We do ask patients, like, if they're comfortable sharing their pronouns, to do so at the beginning of group. I was in a group with Charlie. They did share their pronouns. I think it was well respected within the group. The patients in the groups don't necessarily talk as much as like a support group. It's more of like a psychoeducation kind of learning experience. Luckily, there are also a very diverse population at the program. There's people with different gender identities, different race, sexual orientation, religion, kind of just a lot of different diverse identities. But it was really important, that the individual therapist also holds space for Charlie to share more about their identity or concerns while they're partial. So their identity isn't something that they identified as something that was contributing to their depression at this time, or contributing to their suicidal ideation, or any of the, anxious kind of feelings that they were having. So in the intake, it wasn't necessarily the role of the intake evaluator to deep dive into that unless it had been brought up as a main concern. I do, however, think that the individual therapist would need to take steps outright to give space for Charlie to do so. If it wasn't anything that they had questions about or wanted to talk about, then that's totally okay. But I definitely think that giving Charlie that space, if necessary, to talk about it would be very crucial. My third point on this is the discharge planner should work with Charlie to help connect them to gender diverse and LGBTQ community resources if they wish to do so. So in Rochester here, we have a very beautiful community for LGBTQ individuals. So there's a couple of different businesses, there's different groups, there's mental health specific groups as well. And I think that especially with someone that's moving here from California, they may not know about these things. I mean, they might as well, because they do have friends here. So we don't know what their group of friends looks like or what they're already involved in. But I do think that these are things that we should be cautionary of as far as helping with the treatment planning. Letting them know, like, hey, we have access to a lot of resources. What's something that you like to do? What's something you want to be connected with? And they might bring this up for us. So I think that those would all be goals as far as being inclusive for Charlie's treatment. So moving on to diagnosis. So in the intake evaluation, the diagnosis was major depressive disorder, recurrent, moderate. Charlie reports feeling depressed nearly every day on their patient health questionnaire. So it's a self-report. When asked during intake, Charlie rated depression at a 9.5 out of 10 on a 1 to 10 scale, with 10 being the most severe. So over the past 2 months, Charlie reported, like I said before, decreased appetite, unintentional weight loss, anhedonia, significant decrease in ADLs, including like grocery shopping, hygiene, cooking, feeling chronically low energy, low motivation, and fatigue. Charlie also reported having decreased concentration. They were avoiding tasks that were, more difficult or required sustained effort. Charlie reported increased tearfulness, recurrent increased suicidal ideation, excessive and inappropriate guilt, low self-esteem, and feelings of worthlessness and helplessness. At the same point, in the way that we were able to diagnose major depressive disorder, Charlie denied any symptoms of psychosis, mania, or anxious distress at this time. They also reported instances of dissociation where they had, small gaps in their memory. But at this point, they didn't have enough symptoms necessarily, or clinical distress as per the DSM-5 diagnosis. It was added as a rule out for further evaluation. So one of the things as the role as intake evaluators is that we are identifying, what is the main diagnosis right now that we're going to focus on in this acute setting. There is an option for us to add rule out diagnoses for the individual therapist, which will be seeing the patient 3 times. So they have 3 times as much contact with the patient, 3 times as much opportunity to discuss with them, and they'll be able to contact their providers outside of the program to get a little bit more collateral information as far as, what's going on. So after reviewing Charlie's intake information, the PHQ-9, all the information as far as the diagnosis, I personally would say that Charlie should have been diagnosed with major depressive disorder, severe, recurrent. So my criteria for this, or my opinion on this, was that Charlie reports experiencing all 9 symptoms of the criteria, with clear significant distress affecting their ability to care for themselves, work, and maintain supportive relationships. I do feel that there is absolutely an opportunity to do the same kind of work regardless of the diagnosis that's given at the beginning, whether it's moderate or severe. We're still monitoring for suicidality. We're still monitoring for any acute crisis situations. But I think that that's just something that we learn as clinicians as we go, is that looking at it, with a fine-tooth comb, or looking at it with, a magnifying glass for an assignment, we may fall into a different category, just looking back at the whole picture versus when you're sitting with someone one-on-one for an hour and a half. So with all of that being said, absolutely experiencing depression, absolutely symptoms that is, something that we would be focused on in treatment. So as far as treatment recommendations, I feel that Charlie's mental health needs would best be met by a strengths-based person and environment cognitive behavioral approach. So Charlie's experiencing things like low self-esteem, recurrent thoughts of being better off dead, so passive suicidal ideation, and avoiding tasks that lead to an avoidance of self-care. This cycle could be treated with a cognitive behavioral approach. Social cognitive theory hypothesizes that there is strong evidence of reciprocal relationships between a person, environment, and their behavior. Charlie's low sense of self-esteem may be unconsciously reinforced by their low rate of reinforcers in their environment and high rate of self-punishing behaviors, as explained by different behavior theorists in the, in depression. Charlie has been lacking in their normal self-care routines and due to their depressive symptoms and is having difficulties with taking care of themselves. So like we said before, showering, grocery shopping, cooking, and withdrawing socially from friends. So some goals that I would have as far as treatment for Charlie would be helping Charlie to cognitively practice a self-care routine, engage what is manageable for them at this time, taking those small steps towards bigger steps of caring for themselves. From a cognitive behavioral perspective, goals might include collaborating with Charlie to identify what their beliefs are about themselves and the world, so that we can challenge the thoughts that are truly untrue, beliefs that lack evidence, and thoughts that are generally unhelpful in breaking the punishing reinforcement of the depression. So as far as case study and as far as diagnosis, I do feel that there is sufficient, if not more than sufficient case material. Charlie underwent a full 10-day admission to the program in cognitive behavioral groups, and they did individual therapy. The material, I believe, is credible for diagnostic purposes because Charlie provided a PHQ-9 self-report of their depression symptoms, both at intake and at discharge, as well as, like I said, the Columbia suicide severity rating scale. So they did a Columbia at the beginning and at the end, as well as follow-up appointments throughout that full 10 days. So they're being seen by individuals and mental health clinicians and nurses that entire time. So I definitely think that there's enough information, and I definitely think that there was enough as far as diagnosis. So like I said before, they received a diagnosis of moderate major depressive disorder, recurrent, and then they were supervised by mental health clinicians throughout the entire stay. So just as far as like reflecting, I do feel that Charlie will benefit from the outpatient therapists and psychiatrists that we connected them to at the time of discharge. At their time of discharge, we felt that they were ready for discharge because those acute crisis symptoms had been addressed, and they were ready to move into a lower level of care, which would be with an outpatient therapist about every 2 weeks. I think that there was definitely an opportunity to respect and be curious about Charlie's gender identity to see if they wanted support in connecting to gender affirming resources in the community, or if their gender identity had any effect on their depression symptoms that they didn't bring up in intake, that maybe just didn't come up right away, or that they weren't comfortable talking about yet. The partial program itself is designed to serve as an acute crisis stabilization and provides generalized support and psychoeducation for patients. However, I feel like there is definitely an opportunity for more tailored support for patients with diverse gender identities. Charlie's intake was one of my first days of shadowing, and they didn't present as what I would think at that time as being depressed. It's really great in a way that I can look back and see how much I learned in that time as a student, but they almost came off as more like agitated, shaking, unable to kind of focus in the terms of not keeping eye contact. But like I said before, looking back, they were cooperative, they were depressed, and I'm really happy that they did come in for care. After reviewing my research, working on skills, and reviewing the clinical information, I'm happy to say that it was a welcome refresher on the benefits of looking at the facts of a case, leading into the patient's self-report and experiences, and implementing evidence-based practice to treatments. So at the end of it all, Charlie did subjectively well in the program. They had significantly lower PHQ-9 and GAD-7, so the generalized anxiety disorder scales. They presented as well as like less anxious, more present, and had a more relaxed affect. So just some references. Thank you so much for listening today. I really appreciate it, and I appreciate the opportunity.